Hello, my name is Ariana Kamaliazad. I'm a second-year resident at the Internal Medicine Residency in Spokane, and I'm here to present my ACP case, Migratory Neuropathy, recognizing the snowflake in a sea of anchors. My patient was a 55-year-old man with a history of congestive heart failure and diabetes who presented with 12 weeks of progressive sensory and motor polyneuropathy, starting in the ankles but progressing to include the entire lower extremity up to the hips. Concomitantly had a left-sided Bell's palsy. His condition had worsened at home to the point that he was unable to ambulate or care for himself, and so was admitted. He was given a presumptive diagnosis of AIDP and treated with 7 days of plasmapheresis. He did not improve with treatment of plasmapheresis, but did improve after a short course of steroids. He was discharged to rehab where his bilateral distal lower extremity weakness improved, but he had worsening of his proximal lower extremity weakness. One day he woke up and had left upper extremity weakness without any involvement on the right side and was readmitted to the hospital for further workup. At this time, his diagnosis of AIDP was reconsidered. On his CSF studies, he was found to have 38 white blood cells with a lymphocytic predominance and elevated protein with normal glucose, no evidence of infectious etiology in the CSF or autoimmune encephalitis. He had a negative MRI brain. He had a C spine showing C7 disc protrusion, which was chronic and known, but no other pathology. And he had an EMG NCS showing severe peripheral asymmetric neuropathy with axon loss greater than demyelination. We also ordered a CT chest, abdomen, pelvis to evaluate for a solid tumor causing a perineoplastic neuropathy. At this time, he was found to have nonspecific mediastinal and bilateral hilar lymphadenopathy. After biopsy showing granulomatous lymphadenitis consistent with sarcoidosis, we decided that the diagnosis that best fit his case was neurosarcoidosis. He had a gastrocnemius muscle biopsy and sural nerve biopsy, which did not show any granulomatous inflammation. He was started on steroids with improvement in his symptoms. Rheumatology was consulted and started him on steroid-sparing therapy, and in the outpatient world with treatment was able to regain his ability to walk. I thought this case was a great opportunity to discuss the phenotypically heterogeneous sarcoidosis. They say each presentation is as unique as a snowflake. With neurologic sarcoidosis, 5 to 10% of patients with sarcoidosis have neurologic manifestations. The most common one is Bell's palsy, which was seen in our patient. It can affect any part of the neurologic axis, all the way from the muscles and peripheral nerves up to the brain, causing seizures, meningitis, vasculitis, hypothalamic dysfunction, and tends to have a patchy nature of involvement, not the symmetric ascending that you would see in AIDP. The diagnosis of neurosarcoidosis in my patient was supported by improvement with steroids but not with plasmapheresis, which argues for an inflammatory but not antibody-mediated process, supported by this patchy involvement, evidence of sarcoidosis elsewhere, and improvement with treatment. It is not refuted by a negative muscle biopsy or nerve biopsy because of the patchy nature of the disease. In this case, the initial diagnosis of AIDP was anchored upon and is a good reflection of anchoring bias. There was also some premature closure bias accepting the diagnosis of AIDP before it was confirmed. All in all, I learned a lot about sarcoidosis from this case, and thank you for listening.